Today's recorded lecture will cover coronary artery disease, kind of a review, and again, acute coronary syndrome. The other things that we're going to explore in this rather long PowerPoint will be myocardial infarctions, unstable angina, CABG, and percutaneous coronary interventions. So here is your review. Atherosclerosis, deposits of fat that harden with age. It's an ongoing process, and this is also known as arteriosclerotic heart disease, cardiovascular heart disease, idiopathic heart disease, and chronic heart disease. So if you need to refresh, please go back and take a look at what you learned about this in level 2. Now, the big thing here with coronary artery disease, if people have this early on in their 20s or their teens or something, and that can happen because of familial predispositions to it. They have not had the time to develop collateral circulation. As we get older and natural hardening of the arteries occurs or fatty deposit starts to build, your body tries to maintain homeostasis. And in doing this, the coronary arteries will develop little offshoots, different little branches, in order to supply that myocardial tissue with an adequate blood supply. This is what collateral circulation is called. If they have issues of chronic ischemia, for whatever the reason, the vessels may be very, very tiny, they have fat in there, or they have plaque buildup. Then the body will try and maintain homeostasis and create these other blood vessels, other detours. One of the things that you want to look at when we're diagnosing coronary artery disease is the presence of CRP. It's an inflammatory response, okay? The heart is inflamed because it's not getting enough oxygen. This is increased in a lot of patients that have CAD. So it has been linked with the plaques and cholesterol. All right, here is vessel occlusion with collateral circulation that has developed. If you notice in A, those little branches coming off of those coronary arteries are very few. Plaque has developed inside, you can see that in B, and as a result, that vessel will do its very best to send oxygenated blood out to the cardiac muscle. Then if you look in C, you can see that it's communicated even further. This is their body trying to maintain homeostasis. Again, a review. Take a look at your modifiable and non-modifiable risk factors for coronary artery disease. You learned this in level 1. You learned this in level 2. But here is kind of a comparison for you. Again, modifiable and non-modifiable. These are important things for you to remember as you're taking the history, assessment history of your client. So how do we take care of it? Control the modifiable risk factors. Some of this is in your control, others is not. Lots and lots of teaching here. Okay, diet, exercise, are they obese? If they're diabetic, they have an increased issue with it. Physical fitness, remember what the FIT formula is? 30 minutes a day, most days. Okay, try and get the weight down. Get their blood pressure down, increase the good cholesterol, and decrease the bad cholesterol. So here's your diet teaching, and you would want to do that with them. You're not the only person to do the diet teaching. Call the dietitian. Provide them with handouts. Give them some websites that they can go and look at. Okay, medications that we can give them to help this. Okay, lipid lowering. Would you believe niacin? Yes, it lowers the LDL and triglycerides. It increases the HDL. But niacin has some pretty potent side effects. Flushing, itching, maybe their tummy's upset, and they may have orthostatic hypotension. These are things that you want to teach your client about, forewarn them. Lopid, okay. This is to decrease triglycerides and increase the HDL. But this one tends to have some pretty significant tummy upsets with it. You can give them bile acid sequestrants. Okay, that's going to increase the conversion of cholesterol to bile salt so that they don't get the cholesterol buildup in the vessels. It does bind with other drugs, though. Okay, decrease cholesterol absorption. Zetia. Be careful when you're giving these kind of drugs. If these people start to exhibit signs of muscle weakness, they may not be able to take these statins. Let your doctor know, and they will do everything that they can to change that. Also, antiplatelet therapy, aspirin. Is this 325 milligrams? It may be initially, but usually they'll bring them down to 81. Plavix, okay? That's a very common one. Now with antiplatelet, you want to teach them about bruising, worrying about falls. And if they do fall, you're going to have to worry about, did they knock their noggin and they have a bleed now? Gerontological conditions to consider with coronary artery disease, well, they're wearing out, okay? They also tend to have a lot of comorbidities. So treat their hypertension. If they're smoking, try and get them to stop. Chantix is a thing that they'll frequently put these people on to stop that. They're inactive, so these are why the things happen. Now, CAD is a chronic and progressive disease. There's an increased O2 demand, okay? And what is their supply? Do they have some lung problems, some comorbidities? With this increased O2 demand, and if they're not getting enough oxygen, they're going to have myocardial ischemia. And this is angina. You may say angina, I say angina. But this occurs when the arteries are blocked at 70% or more. What arteries are we talking about? The coronary arteries. We look at the left main. We look at the circumflex, the right anterior descending, the left anterior descending. Now, the left main, if you look at your pathophysiology of the heart, the first takeoff is called the left main. It's a straight little piece before it goes into the LAD, which is supplying the left ventricle. The circumflex is the artery that goes around the backside of the heart, and then you've got the right coronary artery. Now, depending on which one of these is blocked, they can have an MI in that area. Now, with the left main, we call that the widowmaker. If they're complaining of chest pain, they have ST elevation on their stress test. Their cardiac markers are going up, CPK, MB, and troponin. We're going to take them to cath lab. The first thing that they do with the cath lab when they're actually injecting the contrast into the coronary vessels is very, very gentle injection of the dye. If the blockage is occurring in the left main, that first takeoff, they will not proceed any further. This is a patient that is a candidate for coronary artery bypass surgery. The left main supplies the powerhouse of the heart, the left ventricle. If we send that clot down further, the whole left side of the heart is knocked off, then it can't work. Now, this again is your chronic stable angina. Take a look at that. This is just a review process because we're looking more now at the unstable angina. But it's here because chronic stable angina can get worse and go to unstable angina, okay? So how do we know? They'll talk about the pain. They'll talk about the shortness of breath. We'll see ST segment depression or T wave inversion. Looking at that isoelectric line on your EKG tracing tells you if that's occurring. Usually stable angina can be controlled with drugs and lifestyle modification. Here are the locations and patterns of angina and MI. You know, the typical thing. They take their hand to their sternum and they hold it and they say there's an elephant sitting on my chest, or I feel like there's something squeezing around my chest. This frequently radiates to the jaw and the neck. They may say, I feel like I've got a toothache, and it can go down the left arm. Now, it can be epigastric, and they're going to think that they're just having heartburn. That's a frequent thing that they're saying. And it can go between the shoulder blades. Now, women for many, many years would present to the doctor with these complaints of chest pain. And the doctor would say, oh, you're having a gallbladder attack, because women didn't have heart attacks. Well, we know that women do have heart attacks. But that was the common thought at that time, so they would just kind of let them go on their merry way and test them for gallstones or gallbladder attack. So women were considered atypical for MIs. That has changed dramatically. They will present with these same type of symptoms. Now here's another type of angina. This is called Prince-Metal's or variant angina. Doesn't happen real often. It can happen in people that have vasospasming of the coronary arteries, Raynaud's phenomenon, heavy smokers. Some of their neuromuscular toxins that people can be exposed to, which will present as Prince-Metal's angina. So this is pretty rough. My husband had Prince-Metal's angina. I worked in coronary care. He was having chest pain, so they took him to cath lab, and they actually saw that coronary artery spasm right on the table. It was a right coronary artery. He was young. He was in his 30s. This was crazy. No family history of coronary artery disease. But they actually saw the spasming occur. Why? It was a neurotoxin that had caused that, something that he had been exposed to in his military life. Okay, Raynaud's is a circulatory thing, and you've learned about that in level 2. Smoking can cause this, and drugs can cause it. Now, silent ischemia occurs in the absence of any other symptoms. This is usually associated with the diabetic neuropathy. As you know, diabetics have peripheral neuropathy, but they can also have this neuropathy occur in the cardiac arteries, coronary arteries. We look at them, and this is also confirmed by EKG changes. So what is our care for chronic stable angina? Decrease their O2 demand and increase their O2 supply. These people will frequently be placed on nitrates. Isosorbide is one of them. Or if they come in and they're having that chest pain, we will be giving them this sublingual nitro. Sometimes EMS will do it. Give it sublingually. It's a tablet that dissolves. If the tablet, the nitroglycerin sublingual, is in a little dark colored bottle because it degrades with exposure to light, or they can do the spray. This is teaching important. They will take one tablet or one spray, and then they will wait 5 minutes. If the symptoms don't resolve, they will do a second one. Wait 5 minutes. If the symptoms don't resolve, do a third one. Don't go 1, 2, 3 sprays. They won't have a blood pressure. Now, if this isn't working, call the EMS. They may have progressed into unstable angina. They can use this prophylactically. A lot of these people are put on perhaps nitro patches, which gives them relief 24/7. These patches have to be changed. Before you put a new patch on them, take the old patch off and wipe off the excess. Otherwise, they're going to be getting too much. What happens with nitro is it dilates out the blood vessels. So this results in a decreased systemic vascular resistance. They get venous pooling and decreased venous blood return. But it does dilate the coronary arteries, which is going to relieve the symptoms. Here are your long-acting nitrates. You would want to teach them. A lot of people with these will get a headache because of the quick vasodilatation of all arteries in the body, including the brain. That's what's causing those headaches. They may have orthostatic hypotension. So I told you that there can be the transdermal, there can be the nitro paste, and there can be oral isosorbide as one of them. Other things that these people will be put on will be ACE inhibitors and ARBs, maybe some beta blockers, calcium channel blockers, and then again, the lipid-lowering drugs. Teach them about these drugs, what to watch for. If they complain about the headache, tell them that that is a side effect of the medication. Give them some Tylenol. Okay, here's your diagnostics for chronic stable angina, chest x-ray. Well, why would we want that? Is the heart enlarged? 12-lead EKG, take a look and see if there are any rhythm disturbances. What are our lab studies? Okay, for angina. Well, you do want a CBC. You want to make sure they have enough hemoglobin, that they're not anemic to carry that oxygen. Okay, what else do you want? A CRP, probably, C-reactive protein. What else do you want? Troponins, serial troponins, not just one, but you will do these over time. Note what the level is and see if it's trending down or if it's staying the same or going up. CPK-MBs, this is an enzyme that is secreted, and you're going to, again, trend that. Let's do a BNP, just because. Are they experiencing heart failure? Okay, echocardiogram, that's going to look at the actual mechanical functioning of the heart muscle itself. What are the chambers looking like? Do we have good muscle movement? Are the valves doing okay? If they're stable, they'll go for an exercise stress test to see if the heart can handle this, or is this getting much worse? EBCT is a calcium scoring, because we can have calcium deposits also in their blood vessels, in the coronary arteries. And then a CCTA is a coronary angiogram, which is done by an injection into a vein, and then they will look at it on the CT scanner. If they're allergic to IV contrast, they may not be a candidate for that one. Okay, the big thing here is cardiac catheterization and angiography. This is a right-sided heart cath and a left-sided heart cath. Now, they can go in and do the right-sided, and that tells you what's going on as far as how the heart is actually working. Is it doing fine? We can see where the blockages are in the coronary arteries, but that's just a diagnostic. That's telling us, yes, they are there. Now, if they have the right and left-sided heart cath, that opens us up to being able to do something to eradicate, lessen, decrease these blockages by doing a percutaneous coronary intervention known as a PCI, a balloon angioplasty, and possibly some stent placements. This is a great way to relieve the blockages if we can do that. Now, not all blockages will amend to that. The left main is one that will not. So patient preparation is very, very important. They will have to be NPO. We will have to have all the labs readily available, a recent EKG, a recent chest x-ray. Let's assess their pulses because we will be going into a blood vessel, and we want to make sure that we're not going to decrease their blood flow. Do you want to know BUN and creatinine? Yes, because we're injecting contrast. Are they allergic to shellfish or dye? And know what that kidney function is before they even go. They do have to sign a permit for this. You better have 2 IVs in case you have to give them emergency drugs. Okay, off they go to cath lab. Tell them, do the teaching before they even go in there. When you come back, you're going to have to lay flat for 4 to 6 hours. They may have to give you lots of blood thinners, so you want to know what their PT, PTT, platelet count is before they go. So these are the procedures that we will be doing. Now, they may be able to open up that blockage by a balloon. What they do is they go up through the femoral artery. They can go in through the brachial artery as well. And they will go up, up, up into the heart. They will inject the contrast in each of the openings of these coronary arteries, all of them. Inject the contrast and identify where the blockage is. They have a pretty good idea by looking at the EKG. They will get to the area. This catheter will have a balloon kind of squished down on it, and when they get to where the plaque is, they will dial up the pressure. This is done in the cath lab. They will say go to 5 centimeters of inflation. Hold it for 6 seconds. The patient may experience some chest pain. So they are monitored very, very closely while they're in the cath lab. They have oxygen on. We're watching the rhythm the whole time. We do numbing medicine to the area. They make a puncture, and they'll have a catheter that will prevent backflow of blood, and then we will place the catheter through that and go up and inject our dye. They inflate the balloon. They'll hold it. They'll take the balloon down, permit blood flow going. Is it holding? Is it staying open? Was the ballooning process enough? Maybe, maybe not. So we also have the ability to go ahead and place a stent. So the catheter will go in, we will inflate the balloon, and we will deploy that stent. The doctors have a really good idea of the size that they need. They will sometimes put in more than one stent. They call those kissing stents, depending on how big that blockage is. Now, there are some coronary arteries that will not lend themselves to a ballooning or to a stent placement because maybe they have a sharp curve in them. And we certainly don't want to rupture that vessel, which is one of the risks of this. They can inflate the balloon, and that artery, that coronary artery, can fracture. It can dissect. Now this person has to go to the ICU. So if they are going to be having an angioplasty and the ballooning and a stent placement, there has to be a cardiovascular surgeon available in the event that they need to go to have that replaced if the artery is dissected. Okay, so here's a picture of a pre-PCI and post-PCI with stent placement. See how narrow that is? In A, they've done the ballooning and they placed the stents. And now you have adequate blood flow to supply that myocardial tissue with oxygenated blood. Okay, so you learned a little bit about acute coronary syndrome in level 2. Here's kind of a picture of it. They may have chronic stable angina. Okay, that can get worse. It can go to unstable angina. They can have a STEMI or a non-STEMI MI. So understanding what's going on, looking at the 12-lead EKG plus all the other monitoring things that we're doing, the labs, presence of pain, is going to direct the care that these people get. So acute coronary syndrome, they can have a partial occlusion of a coronary artery. Okay, that is a non-STEMI, non-ST elevation myocardial infarction. Or they can have a total occlusion of a coronary artery. That would be an ST elevation MI. If it's a partial occlusion, we may not have to get as aggressive, right? Maybe we can put them on blood thinners and get that occlusion to dissolve. If they have a total occlusion, they have to go for an angioplasty, possible stent placement. So unstable angina may be new in onset, or it may be chronic that has converted over to unstable angina. They're resting, they're quiet, they're comfortable, it's not exertional, and they get this terrible pain. So you may have an increase in the frequency, the duration. and there's no reason for it to happen. The pain is lasting greater than 10 minutes. And again, women, this is often undertreated or underrecognized because they think they're having gallbladder disease. So here's your ST and non-ST elevation. This is stoppage of the blood flow through the coronary artery. When that happens, you're going to have myocardial tissue death. It will become necrotic, which is going to set up an inflammatory response now. This happens because of pre-existing coronary artery disease, and as you know, your STEMI is an occlusive thrombus. It has cut it off. A non-STEMI, there is a clot forming, but it's causing the symptoms. Okay, here you can see the blockage, and this is in the LAD. That's scary. Now, if you look just where the circumflex coronary artery is, that's going around to the backside of the heart, that straight segment just before that is the widowmaker. That's the left main. So this goes in layers. Your heart has many layers of tissue, and it will start in the topmost, okay, the innermost layer of the tissue, and then as that blood supply is decreased, it will spread throughout the myocardial tissue. This is actually a picture of tissue that has died. See the area of white there? That's now necrotic tissue. These people, if this isn't caught early enough, can go into cardiogenic shock depending on how big this area of necrosis is. So here are your manifestations. They have pain. It's not really by rest or nitrates. Elephant sitting on my chest, going down to their arm, going up to their jaw. Okay, often occurs in early morning. It's crazy. It's the 3 a.m. MI coming in by EMS. This pain woke them at 3 a.m. The circadian rhythm is starting to swing over. Okay? And if they have diabetes, they may not even know it is happening. Okay, so this is what they look like. Their heart rate is up and their blood pressure is up. Their vasoconstricted and their peripheral blood vessels, their hands, their feet. They're ashen, they're clammy, they're cool to touch, they're diaphoretic. They are scared out of their minds. So take a look at the signs and symptoms. Heart rate goes up initially, blood pressure goes up initially, and then the blood pressure will drop as the damage continues. Their cardiac output will be dropping. Lungs, yeah, listen to them. That'll kind of give you an indication of if this is a right or a left MI. JVD, their heart sounds, they may have a new murmur coming on. So your assessment is important. Nausea and vomiting, yes, that's because of the severe pain. They may have a vasovagal reflex, meaning that heart rate will drop when they're vomiting, which is not good for them in this condition. Okay, why a fever? Okay. It'll go up a little bit in the first 24 to 48 hours because the inflammation process is going. Okay, some of those myocardial cells are actually dying. Within 24 hours, the leukocytes will go into the area of the myocardial tissue that's been damaged. Neutrophils, okay, you're going to see a necrotic zone. The tissue is dead. That's going to be determined by or identified basically by looking at your 12-lead EKG. With an MI, if it has gone untreated, 10 to 14 days after that, the scar tissue is there. The heart muscle is still at a big, big risk. So, stress. If they get a secondary infection, it's going to make things a whole heck of a lot worse. We do get them up, but we're not going to have them run a marathon. By 6 weeks, that scar tissue is now turned into necrotic tissue. There will be no signal going through that scar tissue. It's healed, but because of the scar tissue, it doesn't work well. Ventricular remodeling will start to occur, and that's when our big hypertrophy process starts. The heart muscle gets thicker, and it dilates. And that's trying to maintain homeostasis and compensate for that area that has infarcted. What do we see? Dysrhythmias, yes. That's the most common complication. 80 to 90% of your patients will get that. So it's caused by the ischemia. It's caused by the electrolyte imbalances, Okay, so the most common rhythms are VTach and VFib, and they are the most common cause of death in the pre-hospital period. These are the people that you find down. Annie, are you all right? Start CPR. Get the AED or AED in for them. Heart failure can happen. Are the ventricles greatly impacted? Left-sided and right-sided heart failure. You know the signs and symptoms of these. Okay, so watch for them. They can go into cardiogenic shock because of severe left ventricular failure if they're having an LAD problem. Papillary muscle rupture, those are your valves. The heart muscle is weakened, it's necrotic. It can't hold all those lovely little chordae tendineae to make the valve open and close appropriately. They can have septal rupture if the infarct occurs there. The tissue is necrotic. It will not stand up to the pressures between the chambers. Right ventricular infarct is one of the most common. It's the right coronary artery, and they are going to exhibit signs of congestive heart failure. Now, right ventricular infarct is going to eventually impact the left ventricular, isn't it? So now, cardiogenic shock, they are trying to die on you. We're going to have to get going really, really quickly to prevent that from happening. So they will go for a STEMI or they are having a STEMI. So let's get them to cath lab and do a percutaneous coronary intervention. Or if they're not a candidate for that, let's get some thrombolytic therapy going. Are they a STEMI or a non-STEMI? That is the question. So I did talk to you about this papillary muscle dysfunction. That's going to cause mitral valve regurgitation. Now the left ventricle is already hurting and it's going to get worse. If they develop a left ventricular aneurysm, okay, that can lead to heart failure, pretty pronounced dysrhythmias, VTach, VFib, and they will be having pain. The septal wall rupture, they get a big loud murmur, and now they're in heart failure and they are in cardiogenic shock. They have to go for repair of that. Can we do that in the cath lab? Yes, they can. May they have to go to surgery? Yes, they may have to. If they have a ventricular septal wall rupture, they are at a high risk for dying. Okay, complications of an MI. Again, pericarditis. Remember that this tissue has been compromised for oxygen. It's now dead tissue. Okay, and they can end up with an acute pericarditis. You'll know that because they're going to have a lot of pain when they take a breath. They want to sit up and lean forward. You will hear that pericardial friction rub, and it's like an inflated balloon and screeching your fingers across it, or running your fingernails on a chalkboard. They will have ST elevation in all leads because it's the pericardial area fluid that is getting thicker and thicker, and it's compromising the whole heart. You're going to see those EKG changes. Now, Dressler syndrome is a specific type of pericarditis. That develops 1 to 8 weeks after they've had an MI. They're going to have the chest pain, pericardial friction rub. What do we give them? High-dose aspirin. No, not 81 milligrams. Now it's 325 at least. So how do we diagnose unstable angina and MI? Their health history. Get your 12-lead EKG and compare it to previous ones. Make sure you're checking to see are there changes in the QRS complex. Look at the ST elevation. Look at the T-wave inversion. Distinguish between a STEMI and a non-STEMI. They will not have just one EKG. They will have serial ones to see, is this MI getting worse? Is it going to become a global MI? Okay, your biomarkers after an MI. These are going to be your CK, MB, myoglobin, and troponin. We don't just do one, we trend them. And we want to see if they are if they're remaining what they are they going down, or are they going up? We look at an onset, peak, and duration of the levels of these biomarkers. That tells you the progression of the MI. So, for patients with the STEMI, coronary angiography It is not for patients who have an unstable angina or a non-ST elevation MI. Okay. Pharmacological stress testing, they don't get up and run on the treadmill. What we will do is inject a radionucleotide and stress the heart that way. These are for patients who have abnormal but non-diagnostic EKGs and negative biomarkers, what's actually going on. This is a radionucleotide. They will feel their heart racing. You are monitoring them, and this is usually done in nuclear medicine. Okay, so for acute coronary syndrome, your interventions, 12-lead EKG, have them sitting up, keep their sats greater than 90%, 93%, with whatever oxygen delivery system you need. Do they need nasal prongs? Do they need a simple mask? Do they need a non-rebreather? Or is this person going to have to be on mechanical ventilation? IV access? I want more than one. How about you? Nitroglycerin, sublingual, and aspirin, they will chew it. They don't like it. Yes, they will get statins. If they tell you that they've tried statins in their life and they can't take them because they get severe muscle pain, you let your doctor know and they'll give you something else. Morphine, yes, it's for the pain, but it also dilates the coronary artery and helps with the myocardial oxygen demand. Okay, treat the dysrhythmias that they have. If they're in VTAC, let's make sure we're checking our electrolytes. Okay, is it an issue of potassium? We have many potent antidysrhythmic drugs that we're going to be able to administer them. They are in bed rest. Okay, if it's a non-STEMI, we will be giving the antiplatelet therapy and give them on heparin. Why? The action, the time for the drug to work. Cardiac catheterization with the PCI once they are stable for unstable angina or a non-STEMI. Initially, antiplatelet drugs, heparin, TPA, tissue plasminogen activase, all to place. Once we get them more stabilized, they will go to the cardiac cath lab and see if we can do something. For a STEMI, they're going right to cath lab. Okay, here are your pictures. Now I want you to take a look here. As you're looking at those PQRST complexes, the horizontal plane there is your isoelectric line. That is how you know if they have ST depression or ST elevation. It is either below that isoelectric line or above it. In your normal EKG, everything is right on the isoelectric line. For a non-STEMI, they have ST depression. You see that the ST part of that dropped below the isoelectric line. In a STEMI, they have ST elevation. We call these tombstones. Okay, and then again in a non-STEMI, they will have the T-wave inversion. These are important things for you to be aware of. So, a non-STEMI reperfusion therapy. What does that mean? Anticoagulants, yes. Once everything is settled down, we're seeing things get a little better, they will go to the cath lab so we have a look-see. And maybe they will be a candidate for an angioplasty or ballooning. Now, if they have a STEMI, they're going to go right to the cath lab. The goal is they hit the emergency room. Everybody convenes in that room. We draw the labs, get a 12-lead EKG, get a chest x-ray, get those IVs started, give them some nitrates, give them a beta blocker, start them on anticoagulants. And within 90 minutes, get them to the cath lab so we can do the balloon angioplasty and place the stents. We're saving myocardial tissue, but it is 90 minutes from door to catheter to cath lab. Hopefully we can avoid them going for open heart surgery. But time is of the essence. Okay? So your whole team is in there getting them ready. You notify the cardiovascular surgeon that this person having a STEMI is going to be going to the cath lab, be on standby in case we have a bigger problem. Is this consentable? Yes. Do we give them morphine? Yes. Do you remember Mona? Give them morphine, oxygen, nitrates, aspirin. Now this is Mona on steroids. We're going to give them a beta blocker as a cardiac protectant to kind of protect that heart muscle a little bit. So here, your thrombolytic therapy is only for patients with a STEMI. Now, if you don't have a cath lab there, okay, they won't be going. You'll have to transfer them to a higher level of care. This thrombolytic therapy may be heparin, it may be TPA, tissue plasminogen activase, it may be alteplase. This is given IV within 30 minutes of arrival to the emergency department. But you have to know something about your patient. If they've had a recent hemorrhagic stroke, if they have bleeding ulcers, if they've had surgery in the last 2 days, are you going to be giving them blood thinners? Kind of scary situation, isn't it? So you have to be aware of what their history is. Okay, here's your thrombolytic therapy. We're going to be giving some really potent anticoagulants. So start your IVs ahead of time. Have more than enough. Administer according to the protocol. You have to have your lab results there. What are their lab results? I want a CBC. I want a PT. I want a PTT. I want a fibrinogen. Okay, I want a D-dimer. I want all those blood thinning tests. CBC for sure. Do they have enough platelets? Will they be able to handle this? All right, also get your electrolytes right now. Get your cardiac monitoring or your cardiac enzyme monitoring ones. Get your CPK-MB. Get your troponin. Let's get a BNP as well. Watch closely for signs of bleeding. What are the signs of bleeding? Well, yeah, bruising for sure, but can you see that they're bleeding under their skin? Watch for their blood pressure. Is it dropping? Now you're going to assess for signs of reperfusion. That tells you that that thrombolytic therapy is indeed working. Watch your ST segment. Is it coming back to that isoelectric line? And these people will be maintained on an IV heparin drip to prevent reocclusion. They will be in the ICUs. Okay, now, if with acute coronary syndrome, if we are unable to open that vessel back up by either thrombolytics or by angioplasty, they may have to go for open heart surgery. If they failed our medical management, they will have to go for open heart surgery. The other thing is if they have presence of a left main coronary artery, or if all the vessels are loaded with plaque, it's not going to do any good to just fix the one. The others are going to be in trouble. So those are reasons to go to open heart surgery. If their vessel that is occluded does not lend itself to a ballooning and stent placement because of their own anatomy, then they may be a candidate for open heart surgery. If they have a history of diabetes, left ventricular dysfunction, or chronic kidney disease, they probably cannot take that huge dye load that they will need to have in order to do a PCI. So we can have traditional coronary artery bypass grafting. It's known as a CABG. They have to open up the chest for the most part, okay? And they have to put them on the coronary artery bypass machine. Divert the blood flow. The heart is at rest. The heart is not working. It's not beating. We put it to sleep, and then we will have to create a detour around the blockages. Now, there are different ways that we can do this. The internal mammary artery is a really good way to do it because it's already an artery, and we can cut it and reattach it below the area of blockage. So that might be a left internal mammary artery to the left anterior descending. They call that the lima to the lad. Or they may have to do that on the right side. That's one option. Another thing that they can do is they can go ahead and harvest a vein. It's usually the saphenous. But if you remember correctly in anatomy and physiology, that vein has valves. That's how they work. They get the blood going upward. So what they will do is they will cut out the saphenous vein. Someone is doing that while the other team is up getting the heart ready to accept this. They will cut out the part that they need, the segment, and then they turn it upside down, and they will use that as the detour because of the valve problem. Okay, so that's kind of what's going on. Now, if they're having a sternotomy and they're on coronary or cardiopulmonary bypass, the blood is being circulated through that heart-lung machine. You have to watch out because it kind of chops up their platelets pretty bad. So, do you think that these people are getting transfusions during surgery? Yes, they are. So, part of their preparation for this major open heart surgery is what medications are they on, for sure, what is their platelet count, and maybe we have to type and cross them for all kinds of blood products in vast quantities. Sometimes if people are anticipating or planning for open heart surgery, they'll bank some of their own blood. And you learned about that in level 2. I'm sure that you did. So they open up the chest, they cut the breastbone, the sternum, they open it up with a rib spreader, and then they will do their work. They will replace the arteries that by going a detour around the area of blockage. Well, then they take them off bypass, make sure that the heart is working. They may have to give it a shock to get it going again. These people are in surgery for however long it has to be. Sometimes it's 2 hours, sometimes it's 4 hours, sometimes it's 6 hours. It depends. They typically will return to the cardiovascular intensive care for recovery. They don't usually go to a recovery room unless it's a big hospital and they have their own cardiovascular surgery recovery area. What they do then is they, once the surgery is completed, they've done the bypass grafting, they will close the sternum with sternal wires. They will have attached those epicardial leads, and because we opened the chest, these people will have chest tubes, orally intubated, an art line, probably their Swan-Ganz catheter in, or at least a minimum will be a CVP catheter. A urinary drainage catheter, we want to make sure that the kidneys are still able to function. INO is very, very closely monitored here because we can infarct the renal arteries. We can decrease the blood flow to them. So you can imagine what these people look like when they come back, plus the fact that they're probably on many, many drips and they're receiving blood products. So if you want to work in CVICU, you're going to be very, very busy. Now this is kind of a picture of cardiopulmonary bypass. And like I said, the heart is not working. It's quiet. There's no pulse going on in there. And they will have to shock that heart to get it to go again. Watch their platelets. Perfusion to the vital organs is maintained, but it's probably not as good as it would be if the heart were doing the work. Okay, here is your bypass grafting. This is going from the left internal mammary down below the blockage in the left anterior descending. Now there's a blockage over there in the right coronary artery. Can you see that? They may have to use the saphenous vein, which they've turned upside down, to go around the blockage of the heart. So this is a 2-vessel bypass. Can you have more than that? Absolutely. It depends on how much damage, how much blockage is occurring in those arteries. Now, they can do another type of grafting. The radial artery is another potential graft because it's a really heavy-duty artery. But the patency rates are not as good as the internal mammary, but they're better than the saphenous veins because it is actually an artery. Now, they took out the radial artery, so don't you have to be really careful about making sure that that hand is still getting adequate arterial blood flow to it? Yeah, you do. Okay, we can do a minimally invasive direct coronary artery bypass. This is called a mid-cap. So these are going to be pretty much people who have left anterior descending or right coronary artery. They don't have to have a sternotomy. So, oh boy, that's so much better. They make us in a lot of incisions between the ribs. It's kind of a mini thoracotomy. Will they have a chest tube? Yeah, probably. But these people don't have to go on bypass. They do this while the heart is actually continuing to beat. So it takes an awful lot of skill to do this. Okay, off-pump coronary artery bypass is optimal. Sternotomy, yes, but they don't have to put them on the coronary, bypass machine. It is done a lot of times robotically or endoscopically. Now, they can also do something called transmyocardial laser revascularization, where they actually take the laser and they will beam it at the blockage in the coronary arteries and obliterate it. That's very specific. It's done usually in the operating room, and there's a whole lot of setup for that one. Okay, so now let's look at the drug therapy for this. Nitroglycerin. What's it do? Drops their blood pressure. How do we deliver it? Sublingual, PO, and IV. Morphine we've talked about. It's not just for pain relief. It's to decrease the myocardial oxygen demand by dilating out the coronary arteries. Beta blockers is a heart protectant. What about ACE inhibitors? Again, those are heart protectants. They're dilating out those coronary arteries. Antidysrhythmic drugs, there's a whole ton of those. Cardizem, amiodarone, lidocaine. Lipid-lowering drugs, yes. And stool softeners, why? So they don't bear down and create more problems. Okay, in ACS, initially NPO, why? Because if we feed them, that increases the workload of the heart as they digest. We will be teaching them about low salt, low saturated fat, and low cholesterol. Remember your diet teaching. Who's going to help with that? How about the dietitian? Okay, here are your assessments. Do they have these histories of coronary artery disease, angina? Have they had a previous MI? Is there a family history of this? Do they have any valve disease? Are they in heart failure? Do they have a history of hypertension? Are they diabetic? Are they profoundly and chronically anemic? Do they have any lung disease? You remember the relationship between the heart and the lung? And do they have elevated lipids? What drugs do they take? Do question them about illicit drug abuse as well, because that can cause problems with the heart muscle itself. And what brought them into this hospital? Again, ask these questions. This is your intake assessment. How do they look? Are they anxious, fearful, restless, distressed? What's their skin look like? What is their heart rate? What are their vital signs? Do they have a pulse deficit? Are they showing dysrhythmias? Look at the monitor. Look at the 12-lead EKG. Do they have a murmur? What's their blood pressure doing? There's your nursing diagnoses, and you can understand why these would happen, right? So what do we want to do? Take care of the pain, preserve as much heart muscle as we possibly can. What is the appropriate treatment for this patient? Help them deal with the coping. Okay, they're highly, highly anxious. Let them know that whatever we're doing with them while they're in the hospital to take care of this, they will have to be in a rehab plan so that this does not reoccur. They will go through rehab and be monitored closely to make sure that the heart can handle what we're asking it to do, and do what they can to reduce those risk factors. Ambulatory care, follow up with their physicians. Understand the risk factors. Teach them about the drugs that they will be taking afterwards. Your acute care is going to be nitroglycerin, morphine. This is Mona on steroids. Morphine, oxygen, nitrates, aspirin, and beta blockers. Monitor them continuously on the EKG, looking at that ST segment. Listen to their heart and lungs. Get your vital signs. Cluster your care. Don't stress them out. Okay? Start the teaching about where we're going. That is the beginning of your cardiac rehab. Okay, for coronary revascularization, which is going to be your percutaneous coronary interventions. This is your care. They will come back with that sheath out. You assess their pulses before they went in. Now you're going to lift up the sheets, look at the site. Will it be bruised? Maybe. Is it bulging? Is it bleeding? Is that a hematoma? What are their distal pulses? Are they complaining of low back pain? Do they have a retroperitoneal bleed? Do their neurovascular assessment. Did some of this microemboli shower? Have they had a stroke? They will be on bed rest 6 to 8 hours. Now they will have closure devices that they offer that these people may be a candidate for. They will inject a little pea-like substance between the tissue and the artery as a compression device to seal off that artery from where they took the catheter. So monitor them for signs of recurrent angina. Now, will they have some chest pain? Not unusual to have a tiny little bit, but if they're saying, okay, I got that elephant sitting on my chest again, something has gone awry, they have reoccluded, notify your physician immediately. They will have to go back to the cath lab. After a CABG, they're in ICU for at least the first 24 hours, maybe longer, depending on how they did, their other comorbidities. They actually are now moving these people, getting them out of bed as early as even 4 hours after open heart surgery. They got tons and tons of line. I talked to you about that before. Can we get a patient with these lines up? Yeah, we can. First, we'll just sit them at the side of the bed. This is not a one-person action. Have somebody in there to help you manage all these lines. They have chest tubes, a pulmonary artery catheter, an A-line. They're hooked up to the EKG monitor, probably ventilated. Maybe they're extubated, but maybe they'll still have the ET tube in. They will have some form of oxygen delivery device. They're going to have those epicardial pacing wires. They're going to have a urinary drainage catheter and probably an NG tube for decompression. So very cautiously start to increase their activity. But these are the things that you are watching, you're monitoring, you're recording. Okay, I told you about the complications of their coronary pulmonary bypass. It does chop up the platelets, so they have an increased risk of bleeding. Fluid and electrolyte imbalances can occur because now we have extended the size of their circulatory system to go through that. So there can be hemodilutional factors here. They're hypothermic. The blood is cooled as it goes through that bypass machine. So they will be cold when they come back to you. And there is a risk of infection. It's a foreign body in there, isn't it? So your postoperative nursing care for open heart surgery, huge. Bleeding, maintaining hemodynamic status. Too much fluid, not enough fluid. Are they hypotensive? Are they hypertensive? Blood, we're going to be replacing it in electrolytes, so you're chasing those down constantly. Get them warmed up. A bear hugger, which you will see used in many, many ICUs. Watch for atrial dysrhythmias, because those are pretty common with this. Okay, if we did a saphenous vein, or we took an arterial artery, you have to address that site as well. Okay, is it bleeding? Is the dressing intact? Look at their sternal dressing. Is it soaked with blood? Not a good idea. Yes, pain management. They're going to have pain. Prevent DVTs. Get some sequential hose on them. Pulmonary hygiene. They're on the ventilator. Suction as needed. Okay. Get them in the appropriate position. And cognitive. We've tossed an awful lot of drugs at them. They may be at a risk for a stroke. Maybe some emboli got dislodged and traveled. So, neuroassessment is another part of that. Okay, I told you in ambulatory care, they will be going to cardiac rehab. They need to understand the do's and don'ts when they go home from open heart surgery. Hold a pillow to your sternum when you cough, when you deep breathe. You don't want that sternotomy to open up. Okay, monitor their heart rate when they do physical activity. Can the heart handle this increased workload? Now, mostly men will ask about this, resumption of sexual activity. This is a question that is going to be specific to them, their age. They cannot be taking erectile dysfunction drugs if they are put on a long-term nitrate, like isosorbide. So think about that. When to avoid sex, typically 7 days post-MI, or if they can climb 2 flights of stairs and not be in distress doing it. So there's your evaluation. Just what we wanted them to be, stable. Pain minimal, not as anxious. They can participate in some activity, and they understand where they're going as far as their post-op care. Now, sudden cardiac death syndrome is a big deal. This is unexpected death from cardiac causes. A lot of it happens. This is like the heart just stops. These are the people that are found down. These might be those athletes who have this huge, huge heart that they have it now because of all this really aggressive activity, physical activity that they're doing. What happens is there is no cardiac output and there is nothing going to the noodle. So they have no cerebral blood flow. This is most commonly caused by ventricular dysrhythmias if they have some structural heart disease or conduction disturbances that they did not even know about. It was never caught. There's no warning sign, okay? They may not even have an MI or ST elevation. They may have some symptoms if it's associated with an MI coming on, like the typical things, but death is usually within 1 hour of these acute symptoms. So they're going to do all the cardiac workup, okay, and treat accordingly. Hopefully, we've caught them before they go into the sudden cardiac death, okay. 24-hour Holter monitoring if they are young or if they're having chest pain. A monitor is put on them in the doctor's office, and they have to record if they feel something, an irregular heartbeat or chest pain. We can do exercise stress testing. Some people may not be able to participate in that. Why? Maybe they have severe arthritis of the knee. Maybe they can't walk. Maybe they're paralyzed. Maybe they're morbidly obese. Okay, a lot of different reasons for them not to be able to participate in a stress test. We can do electrophysiology studies, and that is going to be looking at the electrical pathway of the heart, and we may have to ablate something that is causing an irregular rhythm. They may be a candidate for an ICD, implantable cardiac defibrillator, if they are having beats that we can't get controlled by doing an electrophysiology study and ablating it, or control it with medication. Now, the thing is, if this is implanted in the body and it senses that the heart is going into that rhythm and will deliver an internal shock to reset that cardiac rhythm. It's a machine. It can have problems. It can fail. People will sometimes come in to have the ICD reprogrammed. If that is the case, it will be firing and they're getting shocked for no reasons. What could have set it off? It could be a whole bunch of different things why it's not working, but they will reprogram that. Antidysrhythmic drugs for sure. And what is this life vest? It will have a defibrillator attached to it. So these are just some of the interprofessional care things that we can provide for them. So with sudden cardiac death, these people are scared. They develop a time bomb mentality. I don't know when I'm going to die. It's just going to happen. So if they have had a sudden near-death episode in their life, they should not be driving a car. The person who is the main wage earner and caretaker of everything going on is now the person that needs to be cared for. Sometimes they will have to have a change in occupation. It's just something to be aware of. I know this was a very long lecture, but I hope you got a lot of valuable information. So this is the end of the lecture for today.